Pernell.
Good to see you. Morning, everyone.
Good morning. Good morning. So I'm looking, we'll give it just a couple more seconds. And then I think I don't have our TV guy to be able to get into my ear says he's all good. Usually for our council meetings, I get a little nod, but I think I'll just have to assume he's got everything he needs in just a moment. So give it 1 second. All right. Well, I think that's enough time. But I just want to say again to everybody who's tuning in across all our platforms, whether that be YouTube, TV34, Facebook Live, you've registered for the webinar, whatever it may be. I'm Mayor Sean Spiller. I'm really, really excited for the conversation we're about to have today. I've got Dr. Chris Pernell with us, and she is really just someone who has been such a leader around the issue that we want to talk about today. Really, when we talk about equity, we talk about the vaccines that are out there. We talk about people feeling comfortable with that. We know there's a lot to that. There's a lot to unpackage there. There's a lot of reasons that exists. There's a lot to talk about. So, with all that, without further ado, let me get started. So, my guest today, is Dr. Chris Pernell. She's a dynamic physician leader, a health and wellness visionary, and a social change agent. In her public health practice, she concentrates on health justice, community-based advocacy, and population-wide health promotion and disease prevention. A public health physician and American College of Preventative Medicine Fellow, she oversees a portfolio that includes population health, strategic planning, community affairs, and the human experience. Her role is to lead health equity and inclusion strategy in an integrated fashion across multiple business units. Known for her spearheading work in the greater Newark area, Dr. Pernell was tapped to serve on the Essex County Civilian Task Force as a medical expert, prison reform, and care for justice involved populations, along with issues such as evidence based wellness programs, civic health, and high quality education, have been areas of impassioned focus. She serves as a frequent contributor across television, radio, and print media, leveraging her lived experiences and expertise as America's public health physician and health equity champion. Dr. Pernell authored a self-published her first work, Letters to My People, and regularly speaks at professional symposia and public forums on topics in the public interest, including racial equity, population health, social justice, community well-being, and faith-based initiatives. Dr. Pernell, thanks for being with us today.
Happy to be here. Thanks for having me.
Well, listen, right now we know we are in the middle of an unprecedented pandemic, the like certainly none of which none of us have seen. From the earlier stages with just, panic, fear, and certainly here in Montclair, we saw our numbers, unfortunately, 63 souls who lost their lives to this virus. We kind of worked our way through that first phase. We learned about masking up. We learned about some of the other ways to stay safe, washing our hands, and doing all the things that we can and have in our control. But now, finally, right, we're engaging in a conversation around that light at the end of the tunnel, if you will, the vaccine. Right, there's lots of talk of vaccine. There's some different versions of the vaccine out there. There's a lot of people with a lot of questions around the vaccine, what that means, where we go from there. But I wanted to have a little bit of a conversation around that. Certainly, it has had an impact on everyone, everywhere. There's no question. But as you know, better than most, it's been especially impactful in a negative way on communities of color. Right. It's something that is not a surprise, but it has certainly exposed, which is something that's already been there, but it's exposed the weakness in our healthcare system, especially in how they support and help our communities of color. Can you tell us a little bit about, in your view, what accounts for some of these disparities that we're seeing now that have always existed, but we're seeing even more because of the pandemic?
Thank you, Mayor. Just a spot on topic, right? So, as you can imagine, I've had frequent conversations around coronavirus, this unprecedented public health crisis that literally ripped across the globe approximately 1 year ago. And I think it's important to provide timestamps for people because then I will juxtapose that against centuries old issues that we've been dealing with. So, our first laboratory confirmed diagnosis of coronavirus in the US was January 20th, 2020. Before then, it is speculated that coronavirus was in the community, but it just wasn't documented. So, from that point until now, we've lost nearly 420,000 American souls. The souls that you've called out in my town here of Montclair, as well as my father, who I lost to this pandemic, being one of that number. So that's unprecedented in and of its sense. And that's what we call a fast pandemic, right? This novel infectious agent that we don't know a lot about. We know something because it belongs to a family of viruses, but we don't know a lot about that causes this widespread devastation and wreaks havoc on every system and sector. But what we do know is that whenever there is a crisis, because of systemic racism, communities that have been marginalized or historically excluded often fare worse and bear a disproportionate burden of that crisis. So let me give you specific stats to help you understand. So when we're looking at mortality in the U.S. and saying how does mortality differ by race or ethnicity, if you look at Blacks and if you look at Native or Indigenous populations, the mortality rate exceeds 1 in 750 for both of those groups. If you look at Pacific Islanders and you look at Latinos, the mortality rate also exceeds the mortality rate of white Americans. So, why is that happening? That's that slow pandemic. That's systemic racism. Racism affects the distribution of resources and access to social determinants of health. So, racism affects education. Racism affects the type of job that you work. Racism affects housing. Racism affects your access to high quality healthcare and your experiences in the healthcare system. And that matters because we know that coronavirus, whether or not you get exposed, is necessarily determined by the risk of event of where exposure could occur. So if you lived in a crowded, cramped dwelling, a multi-generational dwelling where you have one person that has symptoms or is suspicious for an infection, it's hard to isolate. It's hard to quarantine. So a whole household gets infected. If you work in an environment that is cramped, or you work a job that is considered frontline, a job that is considered essential, where you cannot work from home. And those jobs tend to be jobs of a lower wage. Those also tend to be jobs with less income protections. You're forced, because of issues of economic vulnerability, to continue to go to work and expose yourself potentially. So you see compounded risk for certain marginalized groups, and unfortunately poor and as well as Black and brown communities bear more of those risks. So you see higher infection rates, you see higher hospitalization rates. The CDC has been tracking this information as well as others. The Color of Coronavirus Project is whose stats I quoted on mortality, the COVID tracking project as well. And you can look at hospitalization rates anywhere from 3 to 5 times more likely for Black and Latinx and Hispanic communities. So there are definitely these interlocking systems of racism, right, that have impacted where you live, that have impacted where you work, that have impacted your access to care, that makes coronavirus deadlier for certain groups and communities.
So given that, given that there's so many pieces there, right, that are
Mhm.
all connected, but all have an underlying theme, right, that systemic institutionalized racism in many ways that is pervasive and impacts everything. We now have at the federal level, right, someone who at least acknowledges that this is the case, right, acknowledges that these barriers exist, and has committed to trying to get the vaccine out to help address this pandemic in a way that's sensitive to understanding that those things are in place, and he has vowed to help in that way, help get the vaccine into communities of need, overcoming fears. What I guess does it look like for a president or certainly a governor in New Jersey? Our counties are doing a lot of the work of getting the vaccine
Yes,
out, and certainly
yes.
as it moves to the town level, what are things, what are strategies, what are ways that people can all look at as we get the vaccine out, as we have conversations to make sure that we factor in everything you just talked about and ensure that the vaccine is getting to people who need it the most in a timely way?
Sure. Let's break that down into three buckets, right? Because what you've described is we need to be concerned with availability, right? So the distribution of doses from the federal level, those doses that have been allocated to states, and then from the state to counties and localities, right? So that's availability. We have to think about accessibility. And when I say accessibility, are the vaccines available at times that are convenient and conducive to those who need access to them? Where are the vaccines available? Are these vaccines available outside of working hours? People oftentimes can't afford to miss work to get vaccinated. So we're giving people an unfair choice, right? So, where can people get access to the vaccine and when can they get access to the vaccine? And in addition to availability and accessibility, we have to grapple with the issues of historical injustices that contribute to skepticism, oftentimes around clinical research. But even more so, historical injustices, we have to tackle ongoing disparities in healthcare because that necessarily colors someone's experience more broadly with the healthcare system and the academic medical complex. So, what does that look like? That looks like block by block, neighborhood by neighborhood, town and city by town and city, getting folks out in front of community who are trusted, having these conversations in socially and culturally relevant and fluent tones. Someone who can say, I understand the impact of a Henrietta Lacks on your choice and decision to get vaccinated. I understand the impact of a Dr. Susan Moore. Dr. Susan Moore is a Black woman physician in Indiana who had coronavirus, who was very vocal, even in the last days of her death, about how racism was impacting her ability to get appropriate and relevant care. So we have to be able to hit that spot on. There is a public health scholar that I follow closely, and I recommend all Americans to know about, Dr. Camara Jones. And Dr. Camara Jones defines racism as a system. And I think it's important for folks to understand this because this is what I'm talking about when I say we got to talk about availability, accessibility, and then those historical and ongoing disparities. So Dr. Jones says racism is a system of structuring opportunity whereby one group is disadvantaged based on phenotype or the social construct of race. Another group is advantaged by phenotype or the social construct of race, but we are all impacted as a whole, and it saps the strength of our societies. And so, if we have awareness of the systems that are operating, then we can't practice care or we can't have these conversations from an ahistorical perspective. So we all have to have an obligation and an accountability to know the history, to know Tuskegee and how Tuskegee is still relevant today. So then we can think of what are the appropriate interventions and solutions to remove those barriers. That's how you get at health equity.
So to that, and certainly I think you really investing in this in a way that I think will become very obvious here with this next question. Someone who's experienced loss personally, and certainly we're sorry for your loss. You then decided to participate in one of the trials, correct? You participated
Yes,
in the
I did.
Moderna trial, and for all the reasons you just noted and the context you provided. Right now we know the history. We know what the history of America has been, and now all of a sudden there's a vaccine trial, and here you sign up. Explain, that's going to sound a little risky to some people. That some people are going to be a little hesitant to do something like that. Yet you chose to do it. Can you tell us why? Can you tell us a little bit about what that's like? I think people are going to want to know what that means. I think that goes a lot to people feeling comfortable with the safety, and get into really your thinking around that.
Sure. So imagine this. Back in spring 2020, New York and New Jersey were very much the epicenter of this pandemic. We knew less then than what we know now about coronavirus. Vaccines were still very much a part of our scientific imagination and discovery, right? We were about to embark on 5 phases of the clinical trial process. I just lost my dad on April 13th. Not only did I lose my dad, I had seen the hospital where I work nearly filled to the brim with coronavirus patients in every bed, and those persons being predominantly Black and Brown. Imagine my sister, who's a breast cancer survivor, my oldest sister, has now gotten infected with coronavirus because she worked a frontline position at a large chain retail and didn't have appropriate access to PPE. And her diagnosis was confirmed in the week that we had the virtual burial services for my father. So there is a lot that's happening in my life personally. There's a lot that's happening in my role as a public health physician. And I need a way to be a part of the solution. I believe in public health science. I got into public health because it is a profession, a passion, and a calling for me. So believing in public health science, but being personally devastated and professionally witness to how destructive the pandemic has been, I needed a way to be a part of the solution. And the best way for me to be a part of that solution and to help beat back and undo some of those inequities that I've been describing was to volunteer. And I know the concerns that people have about clinical research. So I did my homework, right? Me being a physician, it was still imperative for me to do my homework. I asked loads of questions. By this time, we're at early to late summer when we know the phase trials are entering the late stage, or we call phases 2 and 3, and they're going to be taking on thousands and thousands of participants and volunteers. So we had preliminary data that had been published. I knew that there were no obvious causes for concern around the safety profile because phase 1 data had been published in the New England Journal of Medicine. I knew by talking with the study team that in the second phase that there hadn't been any serious medical events. So I was doing my homework. I knew that the process was ethical, meaning that participants knew that it was voluntary. Participants knew that they could withdraw their participation at any time. There was no undue stress or burden to participate, and that participants were allowed to ask as many questions. So that's what I'm describing as informed consent. And that's what has not been there in those examples of medical exploitation and experimentation that a Tuskegee perpetuated, or that even a Henrietta Lacks did not have afforded to her. So I did all of those checks and balances. And I was motivated to say, I can do this. We all have a different role to play. This was a role that I could play. It wasn't an easy decision. And when I say it wasn't an easy decision, meaning I did this with full weight of understanding the consequences. My family was like, are you sure you need to do this? We've experienced a lot of loss. And I felt at peace in that decision. I said, yes, I can do this. And so I got my first injection at the end of August. I got my second injection the first week of October. I can tell you that when I got my first injection, it felt very similar to getting the flu vaccine. I had pain and tenderness at the injection site, never to the point where I couldn't do my job. I was still reporting to the hospital. I had headaches. I had developed headaches across several days. And I had some low grade temperature spikes, but never anything that is officially declared a fever. And before you knew it, at least 2 to 3 days, I was back at my baseline. And so I progressed. I had frequent safety checks during this process. I had an app on my phone where I would have to check in to say I do or do not have certain symptoms. I had people who would call me from the study team to say, how are you doing? I have a chronic back issue. I pulled my back during this trial. So I was closely evaluated to ensure that this wasn't something that happened because of that first dose vaccination. And we could definitively say this most likely happened because of mechanical strain. I was doing a lot of work at the hospital. And so I want to make sure people understand that process because we didn't cut corners around this science. So that was happening in my experience. By the time I got the second injection, it was a little bit different. And at this point, I still don't know if I've received placebo or if I've received the actual vaccine. And the study team, they don't know either. We're what's called double blinded. And so I get the second injection on October 2nd. That injection was different. By the end of the day, I had very severe fatigue. I felt like I couldn't move. I felt like I couldn't get out of my car. And I literally sat in my car for about 20 or 30 minutes. I gathered and collected myself. My temperature spiked almost to 100. But then the next morning, I was up and I was doing work for the Essex County Civilian Task Force. It was literally that short-lived of the symptoms that I experienced. My headache would usually linger for a few days longer, but then the headache would go away. So for me, that was an acceptable risk. 2 days, 3 days max of any symptoms for the advantage of advancing the ball to say, is this safe and effective for the broader population and for having personal protection for myself. And so it was worth it. And the last thing that I will say is I had to participate for me in the back of my mind. I'm saying I have to participate because historically, Black and Brown persons don't participate in clinical research. And they don't participate in clinical research for those very same issues that I articulated at the beginning: issues of access, issues of availability, and issues surrounding systemic racism. And so this is a way to beat back that inequity. And specifically, Moderna, the trial that I participated in, roughly had about 20% of the 30,000 Americans who participated that were Latino, Latinx, about 10% that were Black or African American, roughly 25% were 65 or older, and roughly 17% had chronic health conditions. And I also have a chronic health condition, so I met that criteria as well. In Pfizer, so these are both of the candidates that are currently approved through emergency use authorization, we saw similar demographic profiles. About 26% of the participants were Latino or Latinx, about just shy of 10% were Black or African American, and about 21% were elderly. And so having that type of participation was important, and me being able to weigh in on that participation was equally motivating.
Well, first, after hearing that, I want to say thank you, right? I mean, thank you for really for doing that. That's the goal. That's going to help everyone. That's going to help all of us. So we really thank you for participating. And I think as you counterbalance and what you ended with, all the reasons why so many, all of us in communities of color are nervous about vaccines and the history there. It is important, right? I mean, I heard you touch on it there. It's important for people of color to be included in the trials if we're going to look at efficacy and making sure there's not some other variable that might have an impact or whatever. Why is that so important? That you cited those, you cited the study numbers there. You cited how it was representative of a wide group of people, much like America is. Why is that so important to get all the different groups there?
Very, very good question. So it's important because when you have a vaccine candidate, and this is also true, I should say, more broadly as well. But when you have a vaccine candidate in particular, you want to be able to say that the results are generalizable, meaning that the results will be the same regardless of race or ethnicity, that the results will be the same regardless of age, that the results will be the same regardless of sex or gender identity, and that the results will be the same regardless of chronic health conditions, right? So we being the scientific community, I did not lead the study, but the scientific community, and in particular the researchers, were able to conclusively answer that the effectiveness or efficacy was the same across all of those different demographic categories, right? So Pfizer's efficacy was reported around 95%. Moderna's efficacy was reported around 94 and some change percent. And both of those, I want to make sure the public understands, those are mind-blowing efficacy rates. Not the CDC, the FDA had established a benchmark and said that any coronavirus vaccine that would undergo the emergency use authorization process had to have been proven to prevent coronavirus illness and in particular severe disease in at least 50% of the cases. And so we have 94.1 and 95% efficacy. So if I don't have Black and Brown persons participate, it's not that I'm expecting a difference by the biology, but I want to know that in the place, in the exposures that they live, work, breathe, worship, and play, that vaccine is going to be effective. And we can say that. I want to be able to say that across the age spectrum, that vaccine is going to be effective. Because if it's not, then the inequity is only further deepened and entrenched. So that's basically the bottom line. Everything that we do, Mayor, everything, and I want the public to understand this so we can drive accountability as a community. Everything that we do in every sector, we need to say, what is the ethic, what are the equity implications? We have to. If we don't ask the questions, how is racism operating here? If we don't ask, How is health inequities being allowed to be propagated here? We don't remove the barriers.
Well, certainly, that's absolutely an area I want to talk a little bit about, healthcare and what we can do more broadly, and that'll probably be my next question. But before we leave the vaccine specifically itself, you're a doctor, so tell us a little bit. How does this vaccine work, right? I know there's been a lot of talk of this is different than some of the other
Mhm,
ones that have been
mhm,
in the
mhm.
past, right? There's some new technology everyone's hearing of, and when they hear that, they go, oh, wait a minute, how new is this? So walk us through a little of the history of how long some of these pieces have been in the works, and now it's come obviously to fruition. But why is it that you, and certainly you did your homework, but so many others are so comfortable with, no, this is exactly where we should be and it's safe to do, and explain that to us, please.
Great. So there are three important things that I want people to focus on why this process was different than processes in the past to get at a vaccine. Prior to these two mRNA, messenger RNA vaccines being brought to market and approved through the emergency use authorization, on average, vaccine development could take about 10 years, especially across the more notable vaccines that the public is readily aware of. Prior to the coronavirus vaccines, mumps was the quickest to market, and that took 4 years. This was able to be different, one, because of the science itself. mRNA science technology is different. We're not requiring to build viral proteins in the lab, which takes time. We're not looking to grow the virus in chicken eggs, which would take time. Rather, we're saying in the human body, there is a molecule called messenger RNA. This exists in your cells. Messenger RNA is not DNA, so I want to be very clear about that. It is genetic information, but it's genetic information or instructions around how to make certain proteins. Proteins such as enzymes that catalyze reactions, or proteins that are relevant to the structure of the cell, or other processes across the body more widely. So you have messenger RNA in your body, Mayor. I have messenger RNA in my body. So, what scientists said, okay, knowing how the body works, let's make messenger RNA in the lab. And instead of saying make any protein or another protein, let's tell the messenger RNA to make this specific protein that mimics and looks like the spike protein on coronavirus. If you've ever seen a picture of the virus, you see these spikes all around the molecule, right? And those are the spike proteins that I'm describing. So scientists in the lab, they were able to replicate that and say, hey, this messenger RNA is a Snapchat message. It's going to give your body instructions, make this particular protein. So that's what happened. Then they wrapped it in this really fatty substance. That's the PEG. That's the polyethylene glycol that you hear people talk about. Wrap it in this lipid coat because messenger RNA is unstable, right? We want to create integrity around the molecule so that it can do what it's designed to do. So that gets injected into someone's arm. That goes into your cells. Then your cells say, okay, I have this instruction sheet. I'm going to make all of these proteins. You're not being infected with coronavirus. And I want to make very clear about that. You are being injected with a messenger RNA with the instructions to make a spike protein. Now, I said that the technology was different. We have had previous outbreaks that did not say we were totally in the dark. Okay, these previous outbreaks gave us critical information. We knew about coronaviruses more generally because we knew about SARS, severe acute respiratory syndrome. We knew about MERS, the Mediterranean variant, right? Those outbreaks over the past decade or so taught scientists how to focus on the spike proteins of coronaviruses in general. In addition, messenger RNA technology has been worked on and perfected in labs across the decades and had probably made its greatest advances around cancer, but never anything brought to market. So it was the accumulation of scientific knowledge, the accumulation of scientific progress that afforded scientists at this critical juncture to be able to say, based on what I know, I'm going to design a messenger RNA with a code to make a spike protein that looks like coronavirus. We're going to give it to people. Their body is going to do what the body was designed to do, make all of these spike proteins, which can infect you. But the body says, hey, this isn't here normally. What do I do when I find things that aren't normally here? I build an immune response. So the body makes antibodies, the body makes helper T cells, and then the body is primed, pumped, and ready so that if coronavirus, the real thing, comes on the scene, the body is already instructed and taught how to fight. And that messenger RNA instruction sheet, the reason why I say it's like a Snapchat message, because the body gets rid of it after it receives the instructions. It's beautiful. The science in and of itself is really quite illuminating and fascinating, and I believe will prove to be a game changer. That science has not been used in any other vaccine, so hence that science allowed this process to go quicker, but no corners were cut. Another thing that allowed this process to go quicker is the role of the federal government. And I know that has given people pause. But what I mean when I say the role of the federal government is that the federal government did a very smart injection of funds. The federal government put at least 9.5 billion into this process. And what it told drug companies was typically when you work on a vaccine, you do the testing phase first. So you do all of the laboratory work to prove whether or not a vaccine is effective and safe. Then once you have proven that definitively, you work on manufacturing. When the federal government gave drug companies money, it removed some of the financial risk in the process. So drug companies worked on something simultaneously that they used to work on sequentially. That shortened the process. So while drug companies were testing whether or not particular vaccines would be safe and effective, they were also perfecting the manufacturing science and logistics of how to make hundreds of millions of doses. And then the last thing is that the federal government, through private-public partnerships, partner with the J&Js, the AstraZenecas, and the Modernas to say, I'm going to help you raise very large-scale clinical trials. I told you I participated in a trial that had 30,000 Americans. Pfizer had roughly 44,000 Americans. That has not happened before. We don't usually get that number of people participating in clinical research, let alone in a vaccine study. So those three facts, the science is different. We had a leg up of the science. The science mimics a mechanism that the body already has. The fact that the federal government put money into the process so that drug companies could work on manufacturing and testing at the same time. And the fact that the federal government partnered with those drug companies to help them raise very large scale trials allowed us to do something in a record time. The science did not have corners cut. The ethics were not compromised, but that's what allowed us to get coronavirus to market in a year.
Well, I got to tell you, hearing all that, I know that one of my colleagues, Lauren Allert, who's a AP Bio teacher, she's going to love the explanation you just gave, and I think you really, I can see her smiling right now. So really appreciate you breaking that down as to exactly what all of that
Shout out to
is. And
AP
so
Bio teachers.
there, that's it,
I'm
that's
going to
it.
shout out
So.
my AP Bio teachers that I had at Blue Ridge High School years ago. So yay for AP Bio teachers.
Exactly. It's awesome. And we are all appreciative because, that process you talk about, which is good government, when you can
Yes.
infuse those funds smartly, like you talked about, and really have them, which we're all appreciative of that we're working on the distribution infrastructure, if you will, the ability to get that out. That's important. We're seeing that now. I mean, that's the challenge, right? Getting vaccine. We've got vaccination sites set up. We've got places ready to go. It's quantity. It's getting that in.
Yes.
There's been some talk, lots of talk about J&J, right? And J&J's new vaccine that hopefully is coming online pretty soon. What do we know about that right now? How is it different than the others? Everyone's talked about the fact it's like one shot versus two shots. That could be a big game changer. Everyone notes. What do you know about that? How does it differ? How is it the same? And what what can we expect from that?
Definitely. This is all exciting to me. You see me smiling because I'm a public health physician. So this is really all exciting to me. So the two vaccines that I've described, both Pfizer and Moderna, those are messenger RNA vaccines. They both require two doses. Okay. Pfizer has 21 days in between dose one and dose two, and Moderna has 28 days in between dose one and dose two. Those two vaccines do not go into the nucleus of the cell. They don't involve or change your DNA. Okay, that being said, close case. J&J is different. The most salient different, or there are two most salient differences around J&J would be one dose and storage and handling. Uh, we need a very ultra cold chain process for both Pfizer and for Moderna. Moderna's isn't as rigorous or onerous as Pfizer's has been. It doesn't have to be as cold, but J&J is even going to be more convenient and accessible because it can be stored at warmer temperatures and it is has a longer shelf life. Okay, so that has something to say about accessibility, getting it out to community, getting it in places where community can have immediate access, a doctor's office, a fire station, a police station, a school. Those will be easier to do, going and replicating a door-to-door scenario, mobile setup units. We would have challenges with that around Moderna, and with Pfizer, it's just less possible because you need to have that very ultra cold storage. Okay, so those are two big differences. And then J&J science was different. J&J Science used viral vectors, and AstraZeneca is similar in this, uses viral vectors where you have another virus that is what we describe as attenuated. It is weakened, it is changed in some fundamental way, so it cannot infect the person, but it becomes a carrier. It becomes a carrier for the viral proteins itself. And so J&J's vaccine is a DNA vaccine. Pfizer and Moderna are mRNA vaccines. J&J is using the DNA vaccine inside of an adenovirus viral vector to place those proteins into the person, and then again the immune system is mounted. So just slightly different nuances in the science, but the reason why we need all of these different options is because of the level of persons that we have to vaccinate, not just in the United States, but across the globe. You've heard people talk about herd immunity. Getting at herd immunity naturally, I should say, was just not an option. That would be genocide. Because you can't predict how many people would die. It could be millions. And that is not a risk that any human or government should be willing to consider. So I want to be clear on that. Herd immunity through vaccination is the gold standard and definitely what we need to do with something that has been so devastating as coronavirus. The more options that we have of safe and effective vaccines, the better able we will be able to get at herd immunity. You've heard anywhere from 70 to 85% of the population needing to be vaccinated so that we can stop the spread or the transmission. That's what herd immunity is. So many people have immunity by vaccination that it makes spread less likely. So that's what makes it exciting for me. More products coming to market that are safe and effective. I know we have more tools in the tool chest and that we can get to progress, that we can get to, I won't say a return to normal, but that we can get to a safer place, because we're going to have a new normal, but getting to a safer place so that we can resume those activities that allow us to have the sense of social connectedness, that allow us to have the sense of social fabric and community engagement that we're accustomed to as human beings.
Well, you noted that with J&J coming online, there's that accessibility piece, right? It is because of the not needing the cold temperatures, because of the ability to last longer. We can get it out into places that it's harder to get these other
Yeah.
ones in right now. So that speaks to a little bit of what you started this with, which was around accessibility being one of the key pieces, and some of the disparities that we see in healthcare and certainly in communities of color. As we're getting more vaccine, then and vaccine becomes more available and gets into more places, so there's better access. Here we are doing a webinar on the topic itself around equity and access and trust in the vaccine. What are some other ways? What are the best ways to ensure people, yes, all people have trust in the vaccine, but then really specifically in communities of color, how do we elevate the conversation? How do we focus the conversation so that we are encouraging more people to become vaccinated? What are some of the best strategies to do that?
It matters who's giving the message. And I'm just going to be very clear on that. We have studies to show not just around vaccination, but it matters. Even if you think about infant mortality, you know, we struggle with infant mortality and maternal mortality in the United States because we have an inequity around which babies are dying, meaning by race and ethnicity, and which mothers are dying. We've shown through studies that when the physician is Black babies have better health outcomes, right? And there are several reasons for that, because typically you're going to interrupt that vicious cycle of implicit bias. What is implicit bias? Implicit bias, we all have them. We're human beings. There isn't a human that doesn't have an implicit or an unconscious bias. But what we need to do is to learn to disarm and disengage them. The body has, or the mind, I should say, the mind has developed these implicit biases to make certain processes more automatic. And from an evolutionary standpoint, they have been protective. But on a social interaction standpoint, they actually create barriers. So when you have concordant physician by race and ethnicity to the patient, you see better outcomes. The same is true when we're talking about messaging around the safety and the efficacy of vaccines. We have to elevate the voices of Black and Brown physicians. We don't have enough Black and Brown physicians, Mayor. If I could do one thing through all of this messaging and advocacy, I hope there's some young girl sitting in Montclair today who says, I can be a physician or I can be a scientist. And I hope there is, you know, some Black young girl, some Latino Black girl, some young Asian girl, any girl, but someone who says, I can do that. Because when we have more diverse and inclusive processes, we all do better. I want everyone to walk away learning from coronavirus that all of our destinies are connected. All of our destinies are connected. So if one community is historically excluded or marginalized, your community, even if your community is different by race and ethnicity, is not as prosperous, well, or whole as it could be, right? So we got to get Black and Brown physicians into the pipeline. We got to get Black and Brown, and that's a long-term solution and strategy. We got to get Black and Brown physicians, their voices elevated so they can share their experiences, their insights, and their expertise with communities, because communities that resonates, right? So, okay, this person understands my lived experience. This person understands my history. So when a patient says to me, or a community member says to me, Doc, I don't feel like my doctor validated my symptoms or truly understand my pain. We have studies to show that pain is perceived, whether or not a patient is in pain is perceived differently by the provider based on the race of the patient. As recent as 2016, medical students and those in training still believe the fallacy that Black skin is a different thickness, so Black people don't perceive pain the same. Still, Mayor. So that's why it's important to have those of us who have similar lived experiences and can say, that's not true, or can say to the person across the table, I know your experiences. And I can do that, Mayor. Unfortunately, I have chronic health conditions. I have gone into appointments with journal articles to get a physician to believe my symptoms. And I should not have to do that. But there wasn't a trust, there wasn't a sense of full agency or respecting my full agency to know, even as a physician, what's wrong with me. And so think about the person in the lay public who has that experience. That's why we need Black and Brown physicians and scientists speaking. I need everyone out there to know Dr. Kizzmekia Corbett. Dr. Kizzmekia Corbett is an African-American woman scientist who worked on the team at NIH, who was a part of designing the Moderna vaccine. That everyone needs to know that we were a part of this solution. We, meaning Black people, we were a part of that. And it's a way to say trust is built when systems demonstrate trustworthiness. Okay, so I've given you several examples. We got to elevate the voices of Black and Brown physicians and scientists. We have to center on the histories and the experiences of historically excluded communities, so we validate their fears and concerns, because that's when a person is saying, okay, you hear me, you believe me. So let me look at the science from a dispassionate place and say, this is what the science says. And then the person can make movement along their decision journey. And then those trusted messengers, I say this all the time. We all have expertise. You have expertise, Mayor. I have expertise. The person who's not in a political position has expertise. The mother, the father, the sister, the daughter, the brother, the aunt. We all have expertise. And so those who know their communities, I want to get very hyper local. You know your block, you know your neighborhood, you know your town. You have something that you can add to this process and say, hey, if you want people to know about something or you want people to feel at ease, you need to make sure so and so is a part of the conversation. You need to make sure this dialogue is being had at this time. It's that basic level of truth and insight that has to be plugged into this process. Literally, we need to know community by community, neighborhood by neighborhood, where people are on that decision journey and what we need to do to help them along it. That's health literacy. That's self efficacy, the ability to make an informed choice or decision.
I know we're specifically focusing on the vaccine, but do you see that as the way? Certainly it's first and foremost. I would say I couldn't agree more. Let's get more people of color into becoming a doctor, into the medical profession, into the healthcare profession. All of those pieces so important. Education as an educator, I understand that has such importance as well.
Mhm.
The healthcare system itself, is that the way to see the changes that we need to see in terms of more broadly, and for a healthcare system to be more responsive, to better serve communities of color? Are there other pieces that need to also occur? What are some of those things? How can people who are out there help that process occur? Specifically around healthcare, but certainly any of the other institutions that we all know have similar challenges. But what are some of the ways that there can be additional pieces put around that?
Definitely. So you heard me mention implicit bias, right? So let's talk about the healthcare lens specifically, and then let's broaden it. You heard me mention implicit bias. What healthcare institutions and systems need to do to demonstrate accountability and to provide care that is equitable and high quality? There need to be trainings around what implicit bias is, and there need to be trainings around how to interrupt and disengage implicit biases that all of us bring to the profession. Doctors, yes, we're altruistic, but doctors are no different from citizens. We're susceptible to the same social, cultural, economic, and political forces that have shaped this country of over 400 years. Okay, so in the healthcare system, we have to have that level of honesty to say all physicians must know what their implicit biases are. You can take an implicit association test, and then take an implicit association test. You could take it for race, you could take it for sexual orientation or gender, and you can learn which biases you harbor. And then there are skills that can be cultivated. Awareness is only the beginning, but skills that can be cultivated around stereotype negation. How do you negate operating off of stereotypes and do what we call individuation? Seeing a patient individually, but not seeing a patient as representative of an entire group and the assumptions that may be made about that entire group. So that's just one aspect. But then hospitals also need to think about what is our anti-racism strategy or agenda. How am I making sure that care is not only culturally relevant and fluent, but how am I ensuring that access to care meets the needs of this particular community? Access around time, access around place. Hospitals need to say, am I involving trusted messengers? Am I sharing power with community? Am I doing things in a community participatory model where we look at assets in community and leverage assets to communicate health information? We leverage assets to increase health literacy, and we leverage assets so that people can operate in their self efficacy. Those are just several things that healthcare institutions can do. But let's talk about all sectors more broadly. All sectors more broadly, we go back to this idea of what is a social determinant of health, or as some people describe it, what is a community foundation of health? It's where you work, it's where you live, it's where you pray, it's where you play, right? So your housing, your education, your faith-based settings, the type of job you have, what you earn at that job, all of those things impact health outcomes collectively more than access to care. It's thought that access to care is only responsible about 10 to 15% of your health outcome. The rest of it is determined by place, place-based determinants that I just described. Okay, so what can those sectors do? You can work on ensuring, and this is an issue that's near and dear to my heart because education enabled this young Black girl from East Orange to become the physician leader that she is today. And education enabled my father. I have to backtrack and say this. I told you all I lost my father. My father was 78. My father had a host of chronic health conditions, but my father has quite a heroic story. My father was a young Black man coming up in the Jim Crow South. And like so many Blacks at that time, whether escaping the racial terror of lynching, the oppressive Jim Crow policies, he went north looking for economic opportunity. And ultimately, my father started at Bell Labs in Murray Hill, New Jersey, the famous Bell Labs that is important to three-way calling, caller ID, call waiting, the fact that you go through Easy Pass and you just have a little, Easy Pass thing in your car and it activates that Bell Labs. Okay, so I want to make sure everybody understands. My father started at that Bell Labs cutting grass because that's the only job that was available to him, and that's the only job that he qualified for by credentials. My father didn't go to college. It wasn't accessible to him in 1959 in Richmond, Virginia. But from cutting grass, my father, who always was very good at math and science, would read textbooks at night, would have a second job. My father, the lab had this process of having, since they had so many PhD scientists and professors, they would teach things for people who wanted skills development. And everyone listen to this, on the job training and skills development, education. My father would sit in classes after pouring through a textbook overnight and a professor saying, whoa, how do you know this? Why are you here? Get out of this class. You know as much as I know. So ultimately, my father becomes a member of technical staff. And that is a rung in the research throne or ladder that is reserved for people who have advanced degrees, PhD scientists. My father, who never went to college or had formal training, was a member of technical staff. And so when you say, how do we get at beating back systemic racism? I just gave you two examples. Access to high quality education, because access to high quality education enables or presents an opportunity for you to be employed in jobs with competitive wages. And that drives health outcomes. So it is the responsibility of everyone. In public health, we say it's a health in all policies approach. It is a responsibility of every sector. Dr. Bassett, past New York City Department of Health Commissioner. If you don't know about her, look her up. Black physician, Black woman scientist, Black public health leader, says it is the job of every sector to ask, how is racism operating here? Because if you don't ask the question, and Dr. Cameron Jones says likewise, you can't interrupt it. And that's what I want us to do today, empower all of our listeners to have the assurance that it is safe to ask that question, that it is necessary to ask that question, because that's how we're going to begin to undo the disparities in healthcare. We can't do it without that collective approach across all sectors, because all sectors are implicated in your health and well-being outcomes.
Well, listen, I think in how you just answered that, it segues, very nicely. I know that we're approaching the hour here, but I wanted to open it to some questions, and I had a couple questions sent beforehand, and certainly we'll open it in the chat if anybody wants to post any questions there. I definitely want to post them to Dr. Pernell if you've got some. But as you were answering that, I couldn't help but think of a question that was sent in, so I want to read this one to you. It came from Eric, who shot this in. And it kind of ties into exactly what you're talking about in terms of there are so many other pieces that have that health impact that you wouldn't think of necessarily as health related, right? So he says, I have been working with an organization called Vote ER, which is a group of doctors around the country who are promoting civic health by encouraging their patients and their colleagues to vote. Hundreds of hospitals, UPenn, Mass General, organizations like the American Academy of Pediatrics have endorsed this effort. Research shows there's a direct correlation between voting and health. Would you, Dr. Pernell, pledge to participate in Civic Health Month, and will you encourage your physicians to assist their patients in registering to vote? So that's his question.
Check. We did it at my hospital. We had an that's why I'm smiling. We had an emergency medicine resident approach hospital leadership. We learned about the Vote ER initiative. You can register to vote in the ED lobby of my hospital. and we have done things to encourage what is being described as civic health. And you're spot on. It's very, very important. Kudos to Vote ER. Kudos to physicians and all of those public health leaders stepping forward to increase agency. And so, yes, Dr. Chris is checking that box. I am a true believer in that, and we're working to affect that at my job.
Well, I think I'm sure he's listening and going, that's the best kind of answer. It's just yes. The answer is yes. He asked a great
Yes,
decent
we did it
question,
just
clearly very
just in time,
passionate, right?
just in time that it would still be relevant to the last date that you could register in New Jersey. So you can electronically register right there in the ED lobby.
Oh, look at that. So excellent news there. And I think really with his question, certainly what you were saying before that, I think it's really important for everyone hearing this to kind of realize the connectivity of all the pieces here, right? You talked about it, right? It's a access to great quality education and opportunities. It's the ability to earn, right, financial earnings and the ability, to be able to grow with that. That's an important piece when we talk about health. All these things relate back to health. It's certainly having a diverse group involved in healthcare. When you talk about doctors and nurses and others, let's make sure that we're doing all we can to promote this, in our schools and otherwise. It's important work, and it's going to have impacts on the health side, and certainly, especially, obviously, during a pandemic. So, as we're and again, if somebody on right here has a question they want to put in the chat, I'll try and call a few here. But as I'm listening to all this, and as we're kind of pushing it back to the laser focus around pandemic, virus, where we are. Where do we go next? Like, what are the next things here, right? You talked about the new normal, right? We all realize it's not going to be the same as the old normal. There's going to be a new normal, but we also hear, look, there's the next virus coming. There's the next whatever coming, right? What do we do? How do we, you hear this term a lot in other conversations, but how do we harden our infrastructure? Maybe healthcare, maybe whatever. How do we do some of that work to prepare for the next thing coming, to put us in a good position that we don't just repeat, repeat, repeat? What does that look like going forward?
Definitely. So, whenever I talk about, what are the solutions, what are the action plans, what are the strategies, I like to reference institutions, the powers and the accountability that institutions must exercise, and then individual accountability. And I want everyone to understand that the weight, the onus is on institutional accountability. So, what can institutions, anchor institutions, what can systems do around pandemic preparedness, right? We learned so much, unfortunately, through pain. And we learned how, at the federal level, we weren't prepared, right? We oftentimes lacked a comprehensive and cohesive national strategy for how to deal with this public health emergency and crisis. And from towns to states to regions and to a federal government, we all can ensure that we have the appropriate expertise, that we have the appropriate resources at the ready, so that if a crisis, because another pandemic, unfortunately, will be upon us at some time in the future, and coronavirus will be with us for a while. I want people to understand that. But we have to work on preparedness. In healthcare and in public health, we say that evaluation isn't the last step, but evaluation happens at every step of the process. And we need to understand that preparedness isn't the last step, that preparedness isn't the first step. Preparedness is at every opportunity. It has to become a state of readiness always. So from cities to states, ensuring, and this is the role of the federal government too, ensuring there is appropriate funding into public health and specifically into emergency preparedness and emergency planning. Because whether the crisis is a tornado, whether the crisis is a hurricane, or whether the crisis is an infectious pandemic, communities that are resource poor fare worse. Communities that are saddled with these barriers that I've described all along this talk are worse, right? So that's something that we have to learn and we have to sustain out of this pandemic, being ready. How do you communicate to hard to reach communities? Connectivity. What is the role of public Wi-Fi? Where is the digital divide operating in our towns? Where is the digital divide operating in our states? So that people can be able to be connected and linked into information, even when physical contact, because something that because something that is dangerous. Okay, Mayor. The other things that I think that systems and institutions need to be able to think about is how how do you build in agility into your system, that your system can operate through many modes and mechanisms. In healthcare, we had to understand how to offer a telehealth, and we raised telehealth in a matter of days to weeks so that people's healthcare needs are getting met. Systems of education need to think about that. Public works needs to think about that. Business sector where you have essential staff need to think about that. These are all of the real time things that go into that calculus of keeping us safe. And then as an individual, what do you think about? I talk a lot about wearing a mask, and I never lose an opportunity to tell people to wear a mask and to please wear your mask appropriately over your nose, not down under your chin, fully covering.
We've all seen those images, right? Half hanging down or whatever.
That's the proper way to wear the mask. And focus on, safe distancing, physical distancing. What does that mean? I've had this conversation so many times. We really shouldn't be mixing households, Mayor. We really should have very pristine guidelines to keep ourselves safe during what still is a very dangerous time for the pandemic. We aren't out of the woods yet. And we need to wash our hands frequently. Those three basic public health practices I've described are very similar to other practices that will keep you safe in other types of crises, right? Understanding infection prevention protocols, understanding basic behaviors that are within your power to keep you safe. So that's health literacy, that's self efficacy. Okay, those are the things. And asking yourself, how do I get information? Who are my trusted sources of information? Where do I go to corroborate or to confirm information that is accurate? And knowing that, so that if you find yourself, people have safety kits or emergency kits in their households. It's just this broader sense of individual preparedness and accountability, demanding accountabilities from governmental actors, from healthcare actors, from business industry. That's what individuals and citizens, that very active civil citizenry, that very active civic engagement is are the tools and the things that are going to keep us safe, particularly for coronavirus and more broadly, because we're going to have to continue to do that as we ramp up vaccinations and as we're just prepared more generally.
Well, listen, I will say this. You certainly have done your part and more. So we want to thank you. You're a testament to, I think, why Montclair is so special. It's like everybody's in Montclair, right? So thank you for, but in all seriousness, thank you for everything. Your story, your journey. I think just was really important to kind of include in the conversation, because I think it really speaks to the real impact of this and the importance of this, and why you're involved and engaged and the difference you're making. I think you're a key part in getting the message out, being a trusted messenger, being an important person in terms of making sure others feel comfortable and understand, where we're at, where we're going, where we need to be. So I want to thank you for taking some time to really share with all of us broadly today. I want to thank you for helping to answer some of these questions, put things in perspective, and hopefully, we move that needle a little bit, towards where we need to
Yes.
go. And I know you continue to do that. And I look forward to, yes, seeing you in town, seeing you on TV when I tune in to different shows all the time. So thanks for doing what you're doing. Thanks for spending some time with us today, and we really appreciate you joining us.
Thank you, Mayor. It's been my honor and pleasure. And I just want to leave with this really resounding message of hope and vigilance. We can get through this together.
Couldn't have said it better. Thanks so much. Appreciate
Thank
it.
you.